Good afternoon, everyone. I am Aaron Pollitt, the Provincial Head for Pathology and Laboratory Medicine at Cancer Care Ontario. On behalf of the Canadian Partnership Against Cancer, Cancer Care Ontario, and the Canadian Association of Pathologists, I would like to welcome everyone to today's CAP Cancer Protocol Education session on stomach and esophagus. Before I introduce our speaker and we get underway, I'd like to take care of a few housekeeping items. The session is being recorded, and a link to the recording on CancerView will be circulated to all participants via email when it becomes available. The CancerView website will be upgrading over the next few months. One of the first upgrades is that the CAP education session recordings will be available on YouTube. We will share the direct YouTube link to this session as well as the link to the CancerView page where you can view all previous sessions. Both the live presentation and the recorded presentation are eligible for CME credits. Information for obtaining credits can be found in the session notice. Please note the CME certificates for each of the education sessions will only be issued for 1 month from the presentation date. Please refer to the session notice for the exact deadline. We note that everyone's line has been automatically muted for today's presentation. We have a large number of participants and will not be able to troubleshoot Skype for business issues as part of this call. If you're experiencing technical difficulties, please call the Skype for business support line. We encourage you to submit questions at any time during the presentation using the chat feature within Skype. Chat instructions can also be found in the session notice. During the question and answer portion of the presentation, a moderator will pose the submitted questions on your behalf for as long as time permits and in the order in which they appear. In the chat window, please include the following information: your institution, the name of the individual posing the question, and the question itself. It is now my pleasure to introduce Dr. Dr. Streutker. Dr. Streutker obtained her BSc at the University of Waterloo in the cooperative program in biochemistry. She then went on to earn a master's degree in clinical biochemistry at the University of Toronto. Following the master's degree, she entered medical school at the University of Toronto and then was accepted into the anatomical pathology residency program at U of T. Following this, she completed a 2-year fellowship in gastrointestinal pathology with Dr. Robert Riddell at McMaster University. In 2001, she joined St. Michael's Hospital and the Department of Laboratory Medicine and Pathobiology at the University of Toronto as a gastrointestinal pathologist. Her research interests are primarily mucosal immunology, Barrett's esophagus, and tumors of the upper gastrointestinal tract. She is presently the Deputy Chief of Laboratory Medicine at St. Michael's Hospital and Vice Chair of Promotions and Mentorship at the University of Toronto. Without further ado, I introduce Dr. Streutker to give today's talk on stomach and esophagus.
Thank you, Aaron. Good afternoon, everybody. I'm here to talk about an update on esophageal and gastric carcinomas, predominantly the age-ACC changes in the past couple of years. I'm happy to tell you that there actually are relatively few changes, but it's still a lot to get through, so let's get going. I do have some financial disclosures. Hopefully that will not have any effect on my presentation. So what we're going to talk about today is predominantly squamous cell and adenocarcinoma of the esophagus and gastric adenocarcinomas. And obviously there's a lot of other tumor types in those organs, but we can't cover everything today. So those will be the main focus. We'll also take a quick review through gastric and gastroesophageal junction HER2 testing and a couple of slides on other biomarkers and what's coming in those organ systems. So speaking about the esophagus and gastroesophageal junction, it's a fairly common cause of cancer mortality worldwide, though in North America it's not as much. Squamous cell carcinoma, even when I was a resident...
Hi, Dr. Streutker. Sorry to interrupt. So your slides turned black. So if you can just exit your presentation and restart it. From that slide is fine. Yeah. Great. Thank you.
Okay. Can you see it now? Okay. Sorry about that. We're still having a few issues here. Okay. So worldwide, squamous carcinoma is still the predominant cancer in esophagus, about 90% of the cases. But this has switched over in North America within the last 20 years or so, from when I was a resident to now, in that adenocarcinoma is by far the most common tumor that we're seeing here. risk factors for both types of esophageal carcinoma are being male, and also for squamous, the historical reasons of smoking, alcohol, but also diet and low socioeconomic status. For adenocarcinoma, it's predominantly felt to be reflux in Barrett's esophagus, which most often occurs in patients who are obese. They often smoke, and they have low socioeconomic status. And a weird sort of side effect of Helicobacter pylori is that it's often protective against reflux because it decreases your acid. So it's actually protective against adenocarcinoma of the gastroesophageal junction in the esophagus. So this slide just demonstrates sort of the relative change of esophageal adenocarcinoma. This does include GE junction, where it seems to be the highest increase. It's thought to be sort of leveling off now, but you can really see the distinct rise in that compared to other tumors, which are staying fairly stable or even decreasing. And the incidence varies widely depending on what country you live in. And you can see the top map shows adenocarcinoma, where it's relatively predominant in Europe, North America, and Australia, whereas squamous carcinoma is much more predominant in Southeast Asia, Eastern Europe, Africa, and South America. So there's a big difference in where you live and what your risk factors are. Gastric cancer, in contrast, is actually decreasing in incidence. I gave this talk mostly on gastric cancer, I think 6 years ago, and then it was something like the second leading cause of cancer mortality and the fourth most common malignancy or something, but it is dropping. And you can see the graph on the side shows a slow but steady drop, which is probably because of increased Helicobacter eradication, because H. pylori is still the most common cause of gastric cancer. But of course, there's other causes like heredity, and that's not only the E-cadherin mutation that gives you diffuse gastric cancer, but probably also in terms of Helicobacter infection, that you can have SNPs that increase your inflammatory reactions, so you're more prone. That's still under a lot of study, but it's an interesting idea that hereditary gastric cancer is not just diffuse. Autoimmune gastritis also predisposes you to gastric cancer. Other hereditary things like Lynch syndrome will also do it. Diets high in salt predispose you to cancer, probably because Helicobacter likes a high salt diet. Pickled foods, certainly in Eastern Asia, seems to be linked to the development of gastric cancer, as well as EBV infection. And this is
Hi again. It just went black. So can you exit and re-enter again?
I don't know why it's doing this. It's not doing it on
I'm
mine.
not sure either.
Okay, so every few slides we're going to have to do that. Okay, here's the incidence of gastric cancer by the map, and you can see North America is actually quite low. And so in Ontario, we have something like 1,000 or 1,500 cases a year. But when you look at the incidence in Southeast Asia, it's very high. Mediterranean countries still have a very high rate of Helicobacter, so they still have a fairly high rate. And South America is also quite high relatively. The outcome for esophageal adenocarcinoma by the SEER database is not great. If it's localized, your 5-year survival rate is pretty good, but once it gets to distant spread, it's very poor. This is combining squamous and adenocarcinoma. And when you look at gastric cancer, again, localized is 50 to 60% 5-year survival, but it slowly drops over time. But once you get into the higher stage, it's really very poor and quite quick. When you look at the distant metastases cases at diagnosis, it's about a year or so. About 85% of patients are dead at 1 year. So it's a very aggressive disease when it presents at high stage. And most of them recur very early. A lot of the time it's a local regional failure, nearly half of the time, and that's usually in the regional lymph nodes in the gastric bed. And in many cases you get peritoneal dissemination, particularly in diffuse gastric cancer, which likes to go into the peritoneum.
Hi, Kathy. Went black again. Can I just ask you, are you presenting a program or your desktop?
I think it's the program.
Can you just, can we reset it quickly to present your desktop?
Okay.
So stop sharing.
Oh, right. Okay. And, whoop.
Perfect. And then go to that blue button by the hang up and then share your desktop.
Okay, can you see it?
I see it loading. It's on its way.
Okay.
Great. All right. And then can you just close, if your email program is open, can you close that as well? That might be interfering.
Firefox is closed.
Okay, so that's fine then. Okay, so so you can go back to your PowerPoint and present, and let's see if that keeps it. Thank you.
All right. Okay, so for esophageal and gastroesophageal junction, the HACC 8th edition changes are relatively minor on the pathology side. The main change is finessing the difference in the primary site so that if it involves the gastroesophageal junction with the epicenter less than 2 centimeters into the gastric cardia, it's considered to be an esophageal cancer. But if the epicenter is more than 2 centimeters into the proximal stomach, it stays as a gastric cancer, even if it does cross the gastroesophageal junction. This is a change from years ago when it was 5 centimeters being where the epicenter is as to where you put these. Obviously, this is something that you can do on esophagectomy specimens, but in a center like mine where we do EMRs and endoscopic submucosal dissections, they're not always going to tell us where exactly they are, so it depends a lot on accurate history. So for us, we often are filling in the synoptic with basically saying, I can't tell. And we default to the esophageal one unless they tell us specifically where they are. They are now more formally separating PT1A, which is intramucosal adenocarcinoma, and PT1B, which is submucosal invasion. It's not that those weren't there before, but now they're more specifically integrated into the stage groupings. And they're in both this and in the gastric one, a lot of the changes are in clinical staging to allow them to better prognostify for the patients. The histology has also changed too, and you can see the CAP 2016 in the bottom here showing the different subtypes that we had to check off in the CAP synoptic back in 2016, being basically adenocarcinoma squamous, adenosquamous, and then high-grade neuroendocrine carcinoma, and then basically, I don't know what it is down at the bottom. In the current HACC on the left-hand table, you can see it's subdivided into a number of different subtypes for both squamous and adenocarcinoma. And they also leave the lower-grade neuroendocrine tumors. The main reason they left the neuroendocrine tumors in there is that neuroendocrine tumors, basically, in the esophagus and at the G junction are extremely rare. So I think that they just felt it wasn't worth putting in a whole new synoptic or staging system for a tumor that I've seen 2 in 17 years, and one was a subcomponent of an adenocarcinoma. So that's probably why they left that in there. And that's reflected in the CAP 2017, where you see the majority of these showing up as well. And it again has multiple different subgroups for all of these. So here's your typical adenocarcinoma gland forming. That's not a problem. Here's a squamous one on the right. We see some dysplastic stuff on the surface and then invasive stuff coming into the lamina propria here. So those are usually not difficult for us. We generally don't have to do immuno to separate these, but sometimes if it's a very poorly differentiated one, you would have to think about that. Here's a mixed type one. I actually haven't seen one of these where I've been convinced that it's got both, so this is actually from Web Pathology. The basaloid form we do comment on, whether you call it basaloid or just put it into the differentiation, I think is a bit of a judgment call on this. And the verrucous form, where you're hard put to say that it's actually invasive or is it just really bulky papillary lesions, those can be very difficult to determine, especially on EMRs and ESD specimens where you're not sure exactly how deep it's getting. Here is one of the neuroendocrine tumors I had, and you can see squamous and columnar. This was exactly at the GE junction. So I can't swear that this is esophageal, but it's at the least at the GE junction, which is still very uncommon for neuroendocrine tumors. Tumor grading is not a very difficult thing for us most of the time. Most of the tumors in the esophagus are reasonably well differentiated. It is important that we put some effort into this, though, because the actual staging is now affected by how we grade it, particularly for the early stage tumors. So a well differentiated but deeply invasive tumor will have an outcome similar to that of a grade 2 or 3 superficial tumor, and vice versa to a large extent, that a grade 3 tumor that's superficial will still have a worse outcome. So when the clinicians are staging it, they will definitely take our grade into account. Grading should be done on biopsies if you can, if that's available, because especially for squamous lesions, the patient may well get preoperative chemotherapy and radiation, and then if they proceed to an esophagectomy, there may be no residual tumor. So it does tell us, even on biopsies, we should be making a comment. Don't just say squamous carcinoma, don't just say adenocarcinoma. Try to give a ballpark of the grade at that point, because it might be needful down the road. So they've actually taken away grade 4, which is actually interesting, because in colon they've increased the number of grades, but here they've taken out the grade 4 that used to be here, and you can see this is the older version: well, moderately, poorly, and undifferentiated. Now they've just said well, moderately, poorly differentiated, and undifferentiated. And remember, this is not for all these subgroup ones. This is predominantly for squamous and adeno. So this is basically, we know in our heads how we think we should grade things, but this is the definition of well-differentiated. More than 95% of the tumor forms glands. Moderately differentiated, most but maybe not all forms glands. And poorly differentiated, less than 50% is forming glands, or it's undifferentiated with a glandular component. This is still kind of funny to me, because it talks about, well, you need this percentage, but it does actually say in the AJCC chapter that if there's heterogeneity with respect to grade, you should record the worst or the highest grade. But that would therefore mean if you have 5% of a high-grade tumor, you'd have to call it grade 3, but that doesn't really fit. So I find that very strange. I suppose you could do do the proper thing in the synoptic, but acknowledge the presence of a high-grade component in the diagnostic field. There is a specific comment that you should avoid undifferentiated if at all possible. For those cases, that's where you might want to try immunohistochemistry to try to separate your squamous carcinomas and adenocarcinomas. Basically, if you leave it as undifferentiated, it will be considered to be a grade 3 squamous cell carcinoma in most of the world. Whether that's true here is an interesting question. I haven't asked our oncologist. And here's the very specific definition of squamous carcinoma, where basically the well-differentiated is trying very hard to look like normal squamous epithelium, forming some squamous pearls. Moderately differentiated, it's still trying but not forming a whole lot of keratin. And poorly differentiated, you're not even sure perhaps that it's a squamous carcinoma. And here's a grade 1 adenocarcinoma, and here's a grade 3 where you actually have signet ring cancer, which is distinctly uncommon in the esophagus compared to the stomach. You don't generally get a lot of adenocarcinomas with diffuse or signet ring histology. And here's a squamous one again, and more of almost a verrucous type carcinoma, and the basaloid type, which is poorly differentiated. Staging has not changed much. They have basically, it comes up in the listing as being different, but really what they've done is change the phrasing for I think, high-grade dysplasia or carcinoma in situ, which honestly I would never, ever fill out a synoptic for high-grade dysplasia, because I'm not sure it's worthwhile. So I only start at tumor invades the lamina propria and muscularis mucosae, which ends up, those are both intramucosal adenocarcinomas. Tumor invades for adenocarcinoma, but this is separate slightly for squamous than it is for glandular. Tumor invades the submucosa, tumor invades the muscularis propria. Those are fairly straightforward if you have good landmarks. And then when you get out to the adventitia, then it's how far is it getting, and is it invading adjacent structures or organs? So here's the breakdown of the esophageal anatomy, where you can see the epithelium with the basement membrane underneath, and then there's a loose lamina propria of connective tissue and normally a nice thin muscularis mucosae. Then there's the submucosa where the submucosal glands reside, along with the thicker walled blood vessels that are often our best marker that we're actually in the submucosa, the muscularis mucosa, and then the adventitial tissue around that with the regional lymphatics leading to the thoracic duct. So the only real staging T&M part that's changed is that they've added peritoneum here, where this area down in the 2016 PT4 is slightly different phrasing. So really none of this has changed significantly. Just remember that peritoneum is new in terms of being a criteria for PT4A. And this is how the clinical staging goes. So that you can see the TIS, which is again high grade, I wouldn't put in, but the grade affects whether it's stage 1A or 1B, and all the way down to stage 2A, the grade can affect what the clinical stage is. So that emphasizes the importance of why we're being very careful about the grade. One thing to remember for adenocarcinomas is the presence of a duplicated muscularis mucosae. This has been noted for 20 or 30 years, but if you don't see a lot of these cases, you might not be aware that it's there. So this is the true muscularis mucosae, but right up when you start getting Barrett's, you start getting this upper layer of muscle here, which extends often up into and around the glands to very close to the surface. So at one point it was actually called prolapsing fibrosis, I think. So it can make it very difficult to stage early cancers because these are very well defined. So you get this one here, then you get some duplicated lamina propria, and then the true one down here, but sometimes they kind of blur together. There are some papers that say it can be triplicated. It can get very complicated. But basically what it means is that seeing tumor underneath a layer of muscle, so if you saw something down in this lamina propria, that's not submucosal invasion, and we have to be very careful about that because as EMRs and ESDs become much more common in our practice, if we call something submucosal, they're going to be talking to a surgeon about esophagectomy. So you have to be very sure that something is in the mucosa or submucosa, so we have to really be looking at this. So here's how we stage the intramucosal adenocarcinomas for adenocarcinoma. We say M1 is invasion of lamina propria, M2 is muscularis mucosae, the duplicated layer, M3 is the space between, and M4 is the true muscularis mucosae. This doesn't really have a huge effect on outcome because we don't really know how this separates out. As long as it's intramucosal, the superficial parts of the intramucosal adenocarcinoma have a very low risk of lymph node metastases. And the real importance of this is why doing an EMR or an ESD actually works, because the risk of lymph node metastasis is actually less than the risk of a surgery for a lot of these patients, because remember, a lot of them are older, they're diabetic, they're obese, they do not have, they're not good surgical candidates in a lot of cases. Once you get to M4, depending on the paper, it's a lot more significant, and so the M4s, you might start thinking, well, surgery, maybe, maybe not. Most of our patients for M4, they wouldn't go unless they have some other factor like lymphovascular space invasion or poorly differentiated. Once you get into the submucosa, though, the risk of lymph node metastases is quite significant, both for just finding LVI and for the lymph node metastases. And that's why as soon as you're into the submucosa, the clinicians will seriously start thinking about going for esophagectomy if the patient's felt to be a good candidate. So here's a case where we have this malignant gland filled with necrotic debris, which is a good sign of adenocarcinoma, in a background of fairly dysplastic looking stuff. And you can see pink muscle coming across here, and this gland just coming in underneath the muscle. And so we would have called this an M3 intramucosal adenocarcinoma. Tumor size is something that is in there. I am not convinced it's particularly hugely important. The AJCC chapter notes that the length of the tumor is a surrogate marker for lymph node involvement, particularly in early tumors. So basically saying even if it's not invading too deep, if it's really big, it's still a fairly high risk. This is fairly easy on esophagectomy specimens, but again, on EMR specimens in particular, you really cannot tell how big a tumor is because they're taking out little fragments that are about a centimeter each. And the technique of doing EMR is that you keep doing it and letting the pieces drop into the stomach, and then you pull them out later. And so we get a number of pieces that are puzzle pieces that cannot be put together, and it's just not possible to tell how big something is and what the lateral margins are. If you have somebody who's doing endoscopic submucosal dissections, which our gastroenterologists are starting to do, that's basically an en-bloc resection. I don't think they've done a lot of esophageal ones yet, but we're getting more and more gastric ones. In this case, you can tell size and you can tell lateral and deep margins, but it's still uncommon because it takes a lot of expertise and a lot of time on their side. From our point of view, also, intramucosal adenocarcinoma has often got a lot of tiny foci and a background of extensive high-grade. Measurements are not terrifically reliable. I guess in that case, you could consider using TM for multiple foci, but again, I usually don't bother with that. It depends whether you think it's all across one field, in which case I think it's still considered sort of one lesion. For squamous carcinoma, we don't use the M1, M2, M3, M4 because there isn't a duplicated muscularis mucosae, but we use M1 for in situ carcinoma. Again, I generally do not do the synoptic for an M1 tumor. M2 is invasion into lamina propria, and M3 is invasion into muscularis mucosae. But again, you don't have to worry too much about that in this case because, again, it's still, is it intramucosal or is it submucosal? It's the most important thing. One thing I've seen a couple of times is that the carcinoma in situ can get into the submucosa by extension into the ducts that come up from the submucosal glands, and the submucosal glands themselves can get involved. And I've seen this where there was nothing else invasive and it was just down there. And it's kind of like cervical high-grade dysplasia growing down to the ducts. And you can see here, in this case, there's high-grade squamous carcinoma on the surface, and then it grows down this duct. So it's in the submucosa, but it's not actually invading into the submucosa. And there's a few papers on this that say the outcome is actually quite good in that. So that's just one small thing that I would keep an eye out for in early squamous cancer. The next thing in terms of staging is recording lymphatic space invasion. I would do your best to record lymphatic space invasion separately from venous invasion. Here's a case of lymphatic space invasion. We actually are using a dual stain for D240 and keratin now, which we find very useful because it outlines the lymphatic space and it tells you that the stuff inside it is indeed tumor. Venous invasion, probably similar to colon. There's more and more papers on this now that it probably does predict a bad outcome in terms of distant metastases. I haven't seen it very often in mucosal resections, and so we don't routinely do MOVATs, but this was a recent one we had where it was there, and so now I'm going to probably have to order that more often. Certainly on esophagectomy specimens, it might be worth doing a MOVATs on a few slides to see if you can find venous invasion. For lymph nodes, the comment in the AJCC is that the more the better, and an adequate lymphadenectomy should have at least 12 to 23 lymph nodes. They actually comment that the deeper the tumor is, the more lymph nodes you should be pulling out so that you can get a better evaluation of the lymph node stage. And they've had a clarification of where the regional lymph nodes are. This is perhaps overly detailed. I'm not going to go through in any detail, but I would recommend that you take a look at this if you see esophagectomy specimens so that you can be very clear on what they consider regional lymph nodes. For the stomach, again, the changes are relatively minor. Again, they've reiterated the idea of the GE junction 2 centimeter rule about whether it's gastric or gastroesophageal. Up into the esophagus. True cardiac cancer not involving the GE junction is considered gastric, which makes sense. Again, if they are giving you EMRs or ESDs, you really don't try to fill this out in the CAP protocol. Just say can't be assessed EMR specimen. The other changes that they've done, they've separated the N3 regional lymph nodes into PN3A and PN3B, which this is stated in the AJCC as being a change, but when you look at the previous cap, this I think is there. So I'm not quite sure exactly what they've changed there, or maybe they've just clarified it, but I don't think that's a huge worry for us. Again, they've done several modifications to the clinical staging. Specifically, they pulled out post-chemotherapy, YPT, NM, and they've clarified the clinical versus the pathological PT&M, which again, for us, is not such a huge deal, except we have to really make sure we try to give the post-chemo rad therapy evaluation of what's residual tumor. The histology hasn't changed hugely from before. Here you can see the 2014 cap giving the Loren classification and the WHO classification, as well as some of the other things that you will find. Again, in the AJCC list that they've got, again, they like to leave intraepithelial neoplasia in there, and they have a lot of subcategories in here, most of which are relatively rare. And then the CAP 2017 again puts Loren first and puts WHO as an alternative if you feel like it. I don't generally use the WHO classification, particularly because I think if I called something a poorly cohesive carcinoma, I would probably get a phone call about what is this. So I tend to stick mostly to the Loren, though I do think that the papillary one is somewhat useful in that I think those are fairly low grade, and that sort of expresses the low gradeness of it. So here's your intestinal one where it's forming good glands. These are the ones that usually come out of Helicobacter infection and the intestinal metaplasia to dysplasia route. And here's diffuse gastric cancer with the true signet rings with a big blob of mucin pushing aside the nucleus. And those are usually fairly distinct from the intestinal type, but sometimes you do get mixed tumors. And if they have approximately equal amounts, you can say that, yes, there's an intestinal area and there's a diffuse area. And you can see the ECAT is showing you that it's more or less lost here, but it's still present there. Those are, I used to think they were uncommon, but I see a lot of HER2 cases that I say, well, this might be mixed. Because on biopsies, all you can say is that both are there, and you're not sure if it's equal. So I usually just say this may be a mixed tumor on a biopsy. And here's the mucinous type, more than 50% extracellular mucin pools. These often are a diffuse type. It can be more of an intestinal type with things that are trying to form glands or little strips of epithelia. And this is a nice papillary one where it's forming a very, very exophytic lesion with fibrovascular cores in the little papillae. They're usually quite low grade. A mixed adenocarcinoma, neuroendocrine carcinoma, again, is very uncommon. This is a nice one we had a couple of years ago where you can see very well-formed glands, and this is deep down in the wall, so there's no way these are just reactive things hanging about, and then a neuroendocrine tumor sitting beside it. Medullary carcinoma goes by several different terminologies in that we all have a perception of what medullary is with poorly differentiated tumor with lots of tumor infiltrating lymphocytes. Lymphoepithelial carcinoma is another terminology. Epstein-Barr is very commonly seen in these, particularly in patients who come from Southeast Asia. They may have a more favorable prognosis, and they may respond to PD-L1 blockade, which makes sense. Sorry, I bumped it. Which makes sense because of the inflammatory infiltrate here. And this is the case we had recently where you can just see just sheets of tumor cells, and you can't see the lymphocytes so well at this power, but the EBR shows up just screaming positive. So these are actually kind of more important now to pick out if you see them because it has some relevance to the patient and to treatment. Here's a hepatoid one. This was actually a very difficult case because it was a met to the liver from the stomach, and you can see normal liver off to the side, and then this sort of hepatoid-looking one. And these can mimic hepatocellular carcinoma very closely, but you have to figure out where the primary is, and it may not be easily possible. Thankfully, it's rare, so it's not something that comes up very often. Squamous carcinoma is it happens in the stomach, but it's really uncommon. And this is one we had a few years ago where there were numerous calls from the oncologist to ask, did we really mean that? So yeah, we proved it with P63 and it was negative for all the glandular markers. The only other one I've seen was a drop net from an esophageal squamous carcinoma. So again, it's in the list. It is very uncommon. Grading, again, they've taken away G4, just like in the esophagus. So instead of poorly differentiated and undifferentiated being separated, those are just combined into grade 3. It's not as relevant as in the esophagus because grade doesn't affect the clinical stage like the esophagus does. So just do your best and don't worry too much about it. Again, it has the same basis for the glandular grading. Diffuse and signet ring tumors and also small cell neuroendocrine tumors are considered grade 3. It doesn't predict survival, as I said, but it does seem to predict resectability. And here's a grade 1 with good gland formation, very straightforward, easy to spot, not subtle. And here's a sheet-like one which wasn't trying to form signet ring, so it wasn't considered a signet ring or diffuse type cancer, but just poorly differentiated and didn't mark for squamous markers, so just a poorly differentiated adenoma. And again, here's your classic signet ring, also grade 3. As I mentioned, we do have to be careful about treatment effect. If they tell you, hopefully they will tell you, that there is actually being preoperative treatment, and we need to try to score the degree of regression. I don't see a lot of these, so I don't have any good pictures, but the tumor regression score is basically 0 if there's no viable cancer cells, 1 if it's a lot of fibrosis with only a few single cells or rare small groups, 2 if you can tell that there's been some regression, there's some fibrosis, some areas where you think that it's gone, but it was there before, but there's more than single cells or rare cells left, and 3 when you think there's been very little or no response. Pools of acellular mucin should not be interpreted as representing residual tumor. These will very often leave mucin behind, and you have to assume that it's not there now. Whether it was before, you can put in a comment saying you see pools out this far or pools in lymph nodes, but you should not be giving the p-TNM according to acellular mucin pools. Okay. They've already added margin stuff for EMR and ESD in the previous CAP protocol. So just to be clear that they do want you to try to comment on deep margins. Mucosal margins, a lot of the time just they can't be assessed if it's an EMR, but if it's an ESD, you can do your best on this. And that just depends on your pattern of practice. But I have no fear of saying cannot be assessed for these because you really just can't do it on EMR specimens. Positive margins, particularly in resection specimens, do make a big difference because if you have negative margins, the survival in an R0 tumor is much better than if there's positive margins, which only makes sense. If you're leaving tumor behind, there's a good chance you're not going to do well. LVI and perineural invasion, venous invasion is not separated out again. I would actually fill in the synoptic as present or not present, and then again in the diagnostic field, sorry, you can specify if you're seeing lymphatic or venous or both, because again there's increasing evidence that venous invasion does predict recurrence and distant metastasis. Neither esophageal nor gastric talks about budding in the worksheet or in the AJCC in any significant way. But if you do see it, it might be worth commenting on it because there are some papers indicating that this increased the risk of lymph node metastases. So a lot of this is starting to follow the colonic literature for colon cancer in terms of venous invasion and also for budding. So we should all be keeping a lookout for this for GI tumors in general because it clearly does make a difference. Perineural invasion isn't really changed, so we don't need to worry about that. And again, here's the staging by diagram. Into the mucosa is T1A and submucosa is T1B. And into the muscles, T2, T3 is into the subserosal tissue, and then once you get past the serosa, you're T4. They've changed some of the phrasing here between the CAP 2014 and CAP 2017. Most of it is still pretty much the same, but it's just minor phrasing changes without invasion of the visceroperitoneum or adjacent structures. It's just minor differences. So you just have to double check how far your tumor is going and see which one it fits into. And this goes along with the PT staging in terms of visceroperitoneum and adjacent structures. And again, a diagram showing the depth of the invasion according to, I think this is from the AJCC, but the diagram is actually in the CAP synoptic. The duodenum or esophagus, if you think that it is spreading directly along the mucosa or through the wall into the duodenum, does not count as a T4, and same for the esophagus. If it's going up there, it's not T4. If it is a jump lesion where you have the tumor here and then a lesion out over further along, that you would have to take into a different consideration because that's not, direct spread doesn't count as T4. Okay, so here's an intramucosal adenocarcinoma, just invading lamina propria in the background. Actually, not much changes in there. Submucosal invasion T1B, getting in under the muscularis mucosae, which is generally not duplicated in the stomach, so at least we don't have to worry about that. Here's one that's in the muscularis propria, so it's a T2. And here's subserosal fat extension, so that makes it into a T3. And here we have a couple of diffuse gastric cancer cells right out at the serosal margin, so that's a T4A. Metastases to the lymph node is going to be at least N1, so here's the residual lymph nodes. You can see the tumor in it, probably also venous invasion here, which we don't probably even have to stain for here because it's pretty blatant. Okay, so the staging for lymph nodes, again, they've separated these slightly. Again, that's nothing terrifically new. They do note that if you see a tumor deposit adjacent to a gastric cancer, even if there's no residual lymph node tissue, that it's considered to be a regional lymph node for staging. So this is a significant difference from the colonic tumor deposits where it has its own PN. Here we just say, well, I think it's a lymph node. In those cases, I still consider whether or not it might be venous invasion, and I might do a MOVAT stain to see if there's a region, if there's any evidence of residual vein. But it depends how convinced you are whether it's a lymph node or not. I get questions once in a while about what counts as a regional lymph node, and not to go into this in huge detail, but if you're questioning whether or not a metastasis is a regional lymph node or a distant metastasis, I would refer to this diagram and to the list that's given here as to what is considered. And here specifically they say any other intra-abdominal lymph nodes that are not included in this list are classified as distant metastases. So this is a good reference because it can get confusing once you're outside of this area. If there's something just a little down here by the pancreas, is it regional or is it not? So this is a useful reference. I would comment that from our point of view, we might not know what kind of surgery they're doing, whether they're doing a D1 lymphadenectomy, which is just the ones close into the stomach, or whether they're doing a D2 pushing back into the periaortic lymph nodes. It depends on your surgeon, but there is good evidence that a D2 lymphadenectomy is better for the patient. This is being done pretty much standard of care in Southeast Asia and in Europe now. It's been done in a standardized way and compared to either minimal or D1 lymphadenectomy. And the survival is definitely better if you push them out and get more lymph nodes. It's interesting that the survival is better even if it's N0. You have better survival if you have more lymph nodes. So that's kind of funny because you're saying that even if there's no tumor in them, you're still doing better, which means they're probably resecting lymph nodes that have a couple of isolated tumor cells that we aren't seeing, and we don't hunt as hard as we do in breast for isolated tumor cells, and that is probably where some of the local recurrences are coming from, these lymph nodes that are left with a couple of tumor cells, and then they come back within a couple of years. And you can see the survival that the places that are doing D2 lymphadenectomies, their survival is really amazing, considerably better than doing a D0 or D1 resection that we're seeing in North American populations. Okay, so this is just what I've mentioned before, getting the little bits of tumor out. So stage groupings, which we tend not to worry about too much, but again here, this is not modified by grade in this case, but it does have to do with the N3A and 3B down in the higher stages. All right, the last few things I'm going to talk about is predominantly HER2 testing and then the other biomarkers or things that are coming. We've been doing HER2 testing in Ontario since 2011. Before we were just doing a narrative report, but we've been doing in the last few years a separate synoptic report. And the reason that we're doing HER2 testing is because way back in 2010 now, the TOGA trial came out showing that trastuzumab in combination with chemotherapy made a clinical difference in survival for patients. And this is just a diagram that HER2 is in the same family as HER1, HER3, and HER4. It forms a homodimer with itself. And then trastuzumab, see if my animation still works. Yeah, trastuzumab binds to the HER2 and blocks it from having activity. But it does not affect HER3 and HER4. Whoops. Now, to us, this isn't terrifically exciting, but in cases that we would consider positive for HER2, which means either immunohistochemistry 3+, or immunohistochemistry 2+, or FISH positive, the survival when you add trastuzumab was about 4 months, which is not a lot, but to people who treat gastric cancer, this was considered huge because there are very few things that would shift the survival curve this much, in their opinion. And so that's this is the basis for everything that we do with HER2 and gastroesophageal cancer. There are differences between looking at HER2 with breast versus gastric cancer. We know in breast cancer that the HER2 positive tumors are almost always high-grade tumors, and you can kind of predict when you're looking at the histology that the high-grade ones that are ER/PR negative ones are more likely to be HER2 positive. The difference in gastric and gastroesophageal junction is that the HER2 positive tumors are most often the well-differentiated intestinal type adenocarcinomas, and diffuse type adenocarcinomas is very rarely positive for HER2. The papers quote less than 5%. I think we've tested several thousand tumors here now, and I've seen 2 or 3, so I think it's less than 1%. This also probably explains why tumors at the G junction and actually the esophagus are more often positive for HER2 than the more distal gastric cancers, because diffuse type cancer is very uncommon, even in the cardia, but also up in the G junction and the esophagus. So that is probably, I think that's the main reason. Whether there's some other biological reason why they seem to be more positive than the gastric ones, I'm not sure. The scoring is different from breast. We accept considerably less staining in a way that makes our breast pathologists very twitchy when they look at our slides. It's often very patchy and very heterogeneous staining. So there are some concerns about using biopsy specimens for HER2, even though most studies have shown good concordance with the final resected specimen. But we do have some concerns about that. A cluster of just 5 positive cells in a biopsy specimen or 10% positivity on one slide in resection specimen is sufficient. And staining does not have to be the full circumference of the cells. It's very often basolateral, which goes along with the very polarized epithelial cells that exist in the GI tract. So this is your very typical lateral and basolateral staining that we see for HER2 in the gastrointestinal tract. So grading or scoring depends on the staining visibility, defined as being what magnification can you see the lines between the cells, the membrane staining. So a very good 3+, you can see at low power, and it basically jumps out at you that you can see the outline of the cells. And at high power, it confirms it, but you don't really even need to go on high power to see that one because it's just so positive. A 2+, you cannot really see at 5, or you might see a little hint of brown, but you can't see the lines. And it's not until you get up until to 20 by objective that you can see the lines between the cells. And even here, you're not seeing a huge number of cells, but showing this, but there are some. And when you get to a 1+, you have to be on 40 power, and then maybe you can just see a little smudge of staining between the cells. So when you have a 2+ stain, these are the ones where you have to do in situ hybridization to determine if the HER2 is truly amplified. And this slide is an example of focality in an intestinal type adenocarcinoma where this part is staining very, very strongly, and then it kind of just goes away. I think, especially on resection specimens, that at least some of the time this is due to fixation, and I think it was Eugene Cyr who showed me a case that he had, where he had a tumor that went straight through the wall, and the tumor that was on the mucosal side stained positive, and the tumor that was on the serosal side stained positive, but the stuff in the middle did not stain at all. So is that truly heterogeneity, or is that just fixation artifact? Because we know fixation does affect gastric cancers. And it is frustrating to me that we do not treat gastric cancers terrifically well. In a lot of times in the grossing room, we are more worried about the breast cancer cases, and the gastric cancer cases are left to sit in their own juices and digest themselves. We should actually be trying to do ischemic time, cold ischemic time for gastric cancer, and really for all of our cancers, and not just for breast. But I recognize that that's difficult in our current environment. So people who are eligible for therapy are people who are 3+ by immuno or a 2+ with positive in situ hybridization. Right from the start, in situ evaluation was a lot more straightforward than breast. It was just less than 2 or greater than 2. But the consensus document that we worked on basically also acknowledges the idea of sometimes the ratio is less than 2, but the HER2 average count is over 6. This is usually due to SEP17 having what is quote-unquote polysomy, where you get a lot of SEP17 signals, which prevent the ratio from being above 2. But hopefully you have enough HER2 signals to get the patient over the count of 6 so that they're eligible. So here's the algorithm, just in diagram form. Patient tumor samples, immuno is the first line of testing. 3+ goes straight to positive and gets treatment. 2+ gets ISH, and if it's positive, they can get treatment. There have been some papers that suggest that the response is more in high expressors and not like 3+, and the 2+ that have a ratio that's high, but I don't think that's well studied. And I think the problem is I'm not sure we're ever going to get a good study again that looks at this straight on, because now it's going to be hard to separate that from all the other treatment modalities that are going on. As I mentioned, fixation is a concern. Biopsies might be better to test for HER2 than gastrectomy blocks because of that, but sampling issues therefore are still a problem. We have always been recommending multiple biopsies of tumor, that they get at least 6 to 8 biopsies, but we know that that just doesn't always happen. So I know for cases that I find out, if it's a very small fragment of tumor, I make a comment saying that this is limited, and retesting might be of use if there's ever another specimen. The current testing algorithm is that we test at the first diagnosis. That means that the pathologists are triggering testing. We also know that this means that patients who have early cancers who may never need it, who may never go on trastuzumab therapy or any of the related therapies, they're being tested and they won't need it. But what it also means is that even we don't generally know what stage the case is before when it's coming in, and we don't know if something happens to the patient if they need treatment. Remember that these patients aren't going to survive a long time, and we need to give them as much time as possible. And if we wait until they recur, then weeks are wasted of their lives while we wait for things to get tested. So that was the justification for testing at the first diagnosis. Molecular subtyping is something that there's been a number of publications on in recent years, and this is from a Nature paper a few years back, separating them a little more specifically by the predominant molecular subtype. So matching it with our histology, the chromosome instability version is usually the intestinal histology one. The genomically stable ones here are predominantly our diffuse gastric cancers, and you can see it matches up with the CDH1 mutations that are most often there. EBV is coming up as a separate molecular subtype, which is why I mentioned that before, because it's starting to be something that we need to pull out. You'll note specifically here that they note PD-L1, L2 overexpression here. So these are things that our oncologists are very interested to know, obviously, because PD-L1 blockade is huge now. Similarly, MSI tumors, we don't often test our gastric cancers for MSI, but it is there in a proportion of tumors. And again, it's important because these are hypermutated tumors, and the significance of this is, again, PD-L1. There was a paper in Science in 2017 looking at a very small number of colon cancers and non-colon cancers that were MSI high and seeing if they responded to PD-L1 blockade, and they did. Even some of the pancreatic cancers that were MSI high responded. So subsequent to this, treatment has been approved by the FDA for all solid GI tumors that are MSI high. We thankfully don't have to do PD-L1 immunohistochemistry at this point. All we have to do is the mismatch repair proteins or molecular, whatever the pattern is in your practice. So this is something that we will probably be asked for more in the future, because obviously this blockade is something that is just so popular on the oncology side that I'm not sure if we'll be able to keep up with the demand for this in the future. One paper also noted that you might get asked to do things in patients who have had previous chemoradiation because the chemotherapy might activate the immune microenvironment and provide more utility for the blockade. In the esophagus, other studies looking at VEGF and EGFR targeted therapies doesn't seem to work there. So esophagus is still a difficulty because there's nothing really other than HER2 that's been pulled out in terms of biomarkers. There are papers talking about things like MET, ARID1A, and FGFR, but again, these are all seen in a small proportion of tumors. So whether we're going to be doing molecular on all of these in the future is hard to say. But as we know, molecular is only ever getting more. Gastric and esophageal adenocarcinomas in general are supposed to be among the most mutated tumors around. So while that probably makes it good for PD-L1 blockade because hypermutations seem to create more neoantigens that are more targetable, it does make it hard to create large molecular subgroups. All right, that covers a lot of ground, and hopefully it makes sense. And I think that's it for my presentation, and I'd be happy to take any questions.
Thank you. Okay, where's the...
Something in.
Okay, Kathy, we're just waiting to see if any questions are coming in through the chat box. In the meantime, I just had a question for you regarding PD-L1 requests in Ontario. There have been a couple that have come across my desk, and I know that Chris has seen people requesting PD-L1. What do you recommend with regards to PD-L1 testing right now in Ontario?
For gastric and gastroesophageal cancers, I think it's really very difficult. I don't think we know what antibody to use, and I don't think we know what scoring system to use. We've talked a lot about it here, about whether we should look into it. I would tell the oncologist that MSI is probably a better predictor, and the pathologist. I think I would default to the MSI. If that's what's been approved by the FDA, I'm not sure that there's any other things that are specifically approved for things that are, I mean, it isn't like lung where you have to say what the score is, at least not that I've seen.
No, I have to say that is the feedback that I've gotten from a few other centers. I also noticed in your presentation you used E-cadherin when looking at some of the subtypes for gastric cancer. Do you routinely use E-cadherin when subtyping gastric cancer?
No, generally not. I think that one that I had that was the mixed one, I did it out of curiosity. So, you know, probably shouldn't have spent the money, but I don't generally, because usually the diffuse ones are reasonably obviously the diffuse ones. So, no. I think what I do more often is just a low molecular weight keratin in diffuse cancer, because what I find is it's almost always gone further than you think it has.
Okay. All right, we've had one question that's come through here, and that's in post-neoadjuvant cases where you see pools of mucin and no cancer cells, do you do levels or immunohistochemistry to look for tumor cells in the mucin pools?
Yes. At the very least, I do deepers. And I would strongly consider doing a keratin just to see, because it would really affect the staging. So I think that would be something I would be very prone to do. I think one thing about mucin pools that nobody has a good answer for really is, what do you do with mucin pools and lymph nodes in patients who haven't had chemo-rad? Do you call that a positive lymph node or not? And I honestly don't have a good answer for that. I think I would be prone to call it positive because it got there somehow, but it would have to have a comment to explain it.
All right, we've got a second question here, and that's, how do you report adenocarcinoma in superficial mucosal biopsies if you do not see unequivocal muscularis mucosa, but it's a very complex architecture with invasion?
Okay, that covers two important points, and one is that it's actually really difficult to distinguish high-grade dysplasia from intramucosal adenocarcinoma. The good thing about that part is it doesn't really matter, because nowadays all of those should go to endoscopy first, unless the clinician is looking at it going, wow, this is huge and it's obviously very deep. So if they have some suspicion that this is already an advanced cancer, it doesn't matter anyway. And if they think it's superficial or localized, they definitely need referral to somebody who does EMR or ESD. So on biopsies, I am often reluctant to say adenocarcinoma. I'll say suspicious for, unless it's really obvious. And if it is really obvious, I say at least intramucosal adenocarcinoma. You, on a biopsy, you will almost never, and I would say 99% of the time at least, you are not going to see submucosa. So you cannot tell how deep it's going. You're going to see it in amongst muscle fibers just because that stuff prolapses up into the very superficial mucosa all the time. So all you have to do is say at least intramucosal adenocarcinoma. Leave it to the clinicians to figure out how deep it is. If you want to give them guidance so that not everybody runs straight into the surgeon's arms, you can say if this is a superficial lesion, these are often amenable to mucosal resection or ablation techniques, and a referral to a center that does this is recommended. So, which is something that we put on almost as a standard comment in a lot of our consult cases here.
Another follow-up question. Do you have any tips to identify lesser omentum margin in gross specimens?
Honestly, I don't have a lot of experience with that because we don't get a lot of gastrectomy specimens here. We have a huge mucosal resection practice, so we don't see very many gastrectomies, so I can't really give any good tips on that. I don't know, what about you on your side at Sinai?
Again, our gastrectomies are relatively limited now. It's mainly moved over to across the street. So the only thing I will say is that we try to identify gross surgical margins in the fresh state to avoid any artifact that's done by assessing them post-fixation, and we try to ink them as early as we can on any identified surgical margin.
Yeah.
Okay. That's about that. And then what about ADK and Barrett's esophagus?
Sorry, ADK?
Yeah, ADK. Adenocarcinoma.
Okay.
Adenocarcinoma and Barrett's. What about it? Okay, sorry. We're getting live chat going on here. Okay. So what about adenocarcinoma and Barrett's esophagus? I don't know what the specific...
Basically, almost all adenocarcinomas of the esophagus are Barrett's esophagus related, and so you almost always see intestinal metaplasia and dysplasia in the background. And I think there have been some studies that say even if you don't see it, it was probably there at some point. Look back at the patient's biopsies and what have you. I don't worry about it too much. There are some papers talking about how the ones where you see more of a foveolar pattern of dysplasia might not be Barrett's associated. The cardia ones are always arguable about where they're coming from. Are they coming from short segment Barrett's, or are they coming from some cardiac lesion that either cardiac intestinal metaplasia or somewhat? But basically, the assumption is that the vast majority of adenocarcinomas of the esophagus are coming from Barrett's.
Okay. Well, as I think we've managed to get all the questions through, I would like to, on behalf of the Canadian Partnership Against Cancer, Cancer Care Ontario, and the Canadian Association of Pathologists, thank Kathy for a great presentation today. As a reminder, both the live and recorded presentations are eligible for continuing education credits. In order to request your certificate of participation, please provide your name and email address at the link included in the session notice. You'll also find an optional session evaluation form which we encourage you to complete. The information collected through the session evaluations allows us to ensure that these sessions continue to be informative and relevant to your practice. We appreciate your feedback and suggestions, and please see the session notes for any additional information. I would also like to recommend, just to bring to everyone's attention, that the next session will be in 2 weeks' time, March 27th. And the topic will be vulva, vagina, and cervix, practical considerations and topics in evolution. Thank you very much.